邀请的第一位嘉宾是来自于剑桥大学的 Deborah Vickers， 那么大家也都喊她 Debbie， 就是比较亲切的称呼她是 Debbie。那么她这次给我们分享的是虚拟现实 VR 游戏助力实现更有趣的空间听觉能力训练。那么 Debbie 个人的话是来自于剑桥大学的 Sound Lab 实验室的负责人，她的研究领域非常的广泛，涉及极重度耳聋成年人的言语感知，对于耳蜗死区有非常丰富的理解。同时她的研究还涉及儿童的言语和语言康复，同时她还主持了 TARG 转化听觉研究小组的工作，参与了英国国家健康与临床优化研究院的人工耳蜗植入候选标准指南的优化与完善。那么他今天的演讲的内容就是双侧植入人工耳蜗设备的青少年往往会面临在空间听觉能力上面的一个巨大的挑战。那么他们领导的团队运用了 VR 现实的虚拟现实的 VR 的头显，配合定制的 VR 游戏，开展了一系列的空间听觉能力训练 BEARS， 就是 Both Ears 的一个缩写。那么讲者他会介绍一下这个项目他们的设计和实施以及临床结果。我觉得通过这个演讲我们可以看一下，就是在国外的话他们在做这类实验研究的话是非常的一个严谨。 OK， 那我们先把屏幕先由小助手先给我们播放一下屏幕。
Hello, my name is Deborah Vickers from the University of Cambridge. I'll start by sharing my screen. Okay, today I'm going to talk to you about the BEARS virtual reality training package to improve spatial hearing in young people with bilateral cochlear implants. I'm working with a large group of people from many institutions across the United Kingdom, but I will be presenting the work today. So when we're developing interventions, we need to follow the MRC NIHR framework on complex interventions to improve health. This is a requirement when you're funded by the National Institute of Health Research. So I just thought it would be good to explain a little bit about what's required and what they consider to be a complex intervention. So an intervention is considered complex if it is comprised of a number of components. It targets a range of behaviours. It requires expertise and skill by those delivering and receiving the intervention. Large numbers of potential groups, settings or levels are targeted. And there's flexibility permitted in the intervention and how it's delivered. And this fits well with the work that we are currently doing. So in 2021, the framework for complex interventions was updated to highlight the dynamic relationship between the intervention and its context. And what I mean by context is those factors, individual factors or environmental factors that can affect how an intervention works. The number of people in the family, the home environment, and cognitive levels, some of those factors would be considered context. So the updated guidance moves away from a binary question of effectiveness. and what I mean there is it doesn't just ask, is the intervention effective or not on one measure? And you need to evaluate the intervention considering the real world context and the factors that can affect its usefulness. It's essential to have early engagement with patients, practitioners, here I mean clinicians, and policymakers. And you need to understand how the intervention would be accepted, how you could implement it in the health service. Is it cost effective? Scalable, which means can you increase the number of people using the intervention? Can it be scalable to a large population? And transferable across contexts. So you really have to think about the bigger picture when developing the intervention. They will also request that when you're evaluating the intervention and developing it, that you consider a wide range of research perspectives, methods, to be able to answer questions that go beyond effectiveness alone. So there's four main stages when developing a complex intervention. Starts with the intervention development, then the feasibility of assessing the intervention, then actually evaluating the effectiveness of the intervention before finally implementing it in an impactful way. For the research I'm talking about today, we're at the evaluating effectiveness phase of the research. So the first thing that we had to do was think about what is the problem. So all children in the United Kingdom receive bilateral cochlear implants since 2009. So typically they're simultaneous in one operation since that date. But the trouble with cochlear implants, bilateral cochlear implants, is there can be sources of mismatch across the ears that can affect how useful the devices are. For example, electrode insertion depth may not be the same in both ears. Neural survival could be different. The electrode placement in the cochlea could be different in terms of its positioning, whether there's a traumatic insertion, for example. And also, in the United Kingdom, there's no recognised protocols for fitting bilateral cochlear implants to be able to maximise binaural hearing. Some clinicians, well, all clinicians will check that the levels are appropriate when you switch two devices on, but actually matching the information is not currently conducted. We also don't have any rehabilitation protocols to help use the information from the two ears. So there's no training or fitting protocols currently in place. So we decided to look at training and think what approaches can be effective. So first of all, I'd like to mention a systematic review that one of my PhD students conducted. And this systematic review was looking at training interventions for paediatric cochlear implant users, with many different outcomes considered: vocabulary skills, speech discrimination, melody discrimination, working memory, for example. These are the outcome measures that were typically cited. And Hanine Reyes, who conducted the work, found 9 papers that met the criteria for the systematic review after going through the process of eliminating the other articles. Of the 9 papers, the majority had were low evidence or moderate evidence according to the classification criteria for the quality of the research. The main causes for the low scores were lack of randomization. There were no power calculations were not conducted, and there was no blinding. So blinding being that either the person undertaking the intervention or the experimenter may not know which condition an individual is undergoing. So all studies that Hanine looked at demonstrated significant effect for on-task training. 60% of the studies demonstrated some degree of generalization to other domains. And the greatest effects were observed when there was mixed training of analytic, simple contrasts, and synthetic contrasts as well. Synthetic training alone did not demonstrate generalization, but synthetic training alone did demonstrate some generalization, but analytic alone did not. So synthetic is a much higher level contrast, whereas analytic is the kind of bottom up discriminating individual sounds, for example. Very few studies actually measured retention, which is the continuation of the effect of training after a period of time when the training is no longer being delivered. And only one study actually reported compliance with training. So these are important factors to consider when doing a training study. And quality of life was seldom measured. So we also decided, when thinking about our work, was to think, what evidence is there that learning can take place? So we looked at the literature and found some examples. So Jill First's group demonstrated improvements in localization abilities for adults with unilateral deafness who were trained on localization skills. Yu et al. Simulated unilateral cochlear implant use for single-sided deafness. They were using normal hearing population, but they were also able to demonstrate improvements in localization following training. There's some experiments where unilateral deafness can be simulated with an earplug that also showed improvements in sound localization. And the evidence suggests that these improvements occur due to cue remapping, so the better use of spatial cues, use of monaural frequency cues, so learning to use the cues in one ear, and reweighting, as changing the reliance on some of the unaltered cues while ignoring some of the altered cues. So also when we were developing our intervention, we had multiple discussion groups with cochlear implant users, families and clinicians. So we had a stakeholder group that helped us to develop our intervention. So we had many meetings where we discussed ideas and tried out different approaches. And our groups helped us to design the intervention, the BEARS intervention, design the training protocol, the assessments, the study design, the website, and also our dissemination plan. So they've been involved all the way through to make sure that this intervention is appropriate for them. One example of some really useful feedback is that we've had to develop an iPad version for some children who have balance issues and also for our younger participants. So it's been really important to engage the patients in this work all the way through. So when we're developing our interventions, we go through a series of cycles, and there's been multiple cycles. We've initially developed the materials that we want feedback on. We prepare carefully and have a protocol for meeting with our stakeholders, and then we conduct the interviews. We summarize all of the feedback from the interviews and create action lists, priority lists based on the feedback that we get. And then we create checklists for our research team, which we've prioritized, and then we continue through the loop until we consider we're happy with the result. Okay, so the BEARS is the suite of games that we currently have. So the BEARS suite has a sound source localization game, a speech and noise game, and there's also a spatial music training game. Now I'd like to try and see if I can just show you a YouTube clip. Let me just... Okay, so let me play the clip. You won't hear the sound from the clip at the moment. I'll talk you through it. So we have the three games, music, spatial and speech, that are options to be selected by the user. In this case, they're going to select the speech game. And there's different levels within the games that you can choose. And then once in the game, we have different characters who come and ask for items from the diner. And the goal of the person is to provide them with the food that they've asked for. So you can see down here, there's different items. This is a coffee. But it was wrong, and actually they wanted tea. So there's various people placing orders. So that's an example of the diner. We have an easier version for younger children, which is about making pizzas as well. Let me just move to another game just to briefly tell you. So here we have targets. So in the target practice, you start with targets that you can see, and then the targets become invisible, and you're just using sound to try and hit the target. Can you see it's very faint here? This is gone through a different series of levels. So as you get harder, the targets become much fainter. And the children really enjoy this task, actually. And then finally, I'll just go to the music game. Okay, let me do this one. So this is a game where you have to say which piece of music was higher in pitch. So you'll hear they hear two pieces of music and they have to decide. So it's to help train pitch. And we have rhythm and timbre tasks in the games as well. Okay, I'll stop that there. Okay. Okay, so for our research, we're funded by the National Institute of Health Research. So we have to have a logic model to explain what our intervention is about. So we're targeting 8 to 16-year-old bilateral users of cochlear implants who've got at least 12 months experience. We're training skills of localization, speech and music. And based on the feedback from our patient group, we have a 3-month intervention period in the clinical trial that we're running, and they need to do at least 1 hour per week separated over 2 sessions. Based on the literature, we're using a multimodal training approach, and this is meant to improve generalization. So that's part of the change mechanisms, that will have multisensory integration, and the effects will generalize to other perceptual areas. We expect a change in healthcare because cochlear implant users will be able to self-administer their own care, take a more active role in their healthcare, and it will be available to all clinics. So this also provides equity of care, which is really important. We expect our direct outcomes to be improvements in speech and noise, improvements in localization, and reduced listening effort. And these in turn should lead to improved vocabulary, improved communication, better attention, reduced anxiety, and improved quality of life. So this is the overall logic model for the intervention that we've developed. So context, I mentioned context earlier, and we have 2 areas. We have patient characteristics, which is the developmental age. All these characteristics you can see here are considered important patient characteristics. External environmental context is also the schools, for example, things like the school setting, the home environment, how engaged they are with the technology. And so all of these elements will go into our statistical analysis. We have a mixed methods design. Our main trial outcomes are quantitative speech measures. We have a quality of life measure. We're doing health economics analyses. And then we have qualitative interviews on listening experiences and open questions on listening experiences. We also have a process evaluation, which I won't say very much about, but that's to actually govern the quality of your trial, to make sure people are adhering to the trial and ensuring that the expectations of the researchers is what's actually achieved, so that the clinicians, when they're explaining how to use the bears, they're fully understanding how to do it. So part of the process evaluation is to make sure all the different individuals involved know what they're doing and are delivering the trial in the expected way. So there's various parts of the process evaluation that look at reach, how we delivered the intervention, the context that we're looking at. I think we've talked about context quite a lot. And then scale up, things that we'll be considering later on when we move into implementation in the health service. And for that, we have various quantitative measures such as data logging. We have questions about the environment, qualitative interviews, qualitative interviews that understand the behavior changes. So are we following the logic model as we expect? Are we seeing the effects that we expect? But also qualitative interviews to inform how we will implement the games in clinical practice. So let me just mention something about how we're going to assess effectiveness. So our primary outcome is the spatial speech and noise measure, and we've implemented this in virtual acoustics. We're also using a spatial adaptive sentence list. Now this is something that was, so the adaptive sentence list is a traditional clinically used sentence list, whereas the spatial speech and noise is a newly developed speech and noise task. We're also using qualitative interviews, questionnaires. We're adapting a questionnaire from Quentin Summerfield for, so we have a quality of life measure for binaural hearing. We're using some standard quality of life measures and also some standardized measures to look at fatigue and speech perception in everyday life, as well as looking at vocabulary scale. Now, I just briefly want to show you about the, just show you what the speech tests involve. Okay, so we start off by, we always, for all of our tests, we measure the head size, and that goes into the software to have some head-related transfer function information. We start with a threshold test that helps us work out what signal-to-noise ratio to use for the main test. And the task of the individual is to identify a word out of a selection of 4 words in this first part of the speech test. It's a 4 alternative forced choice task. We adaptively adjust the level, and then we end up with a threshold that we'll use in the main task. Let me just move along to that. Okay, so then we move into the, the speech testing. And within the speech testing, you can see you have to put signal to noise ratio. Well, that's what we got from the threshold test. And then we test them at that signal to noise ratio. Okay, so in the main task, again, they have to identify a word out of 4 options. But the other task they have to do is say whether the second word was to the right or the left of the first word. This is known as relative localization. So in this same task, we get word identification or word discrimination and relative localization. And we use both of these pieces of information to understand performance, to understand binaural performance. Okay, I'll stop that there. See if I can. There we go. Sorry. Okay. So we have these 2 speech perception measures, as I've already mentioned. With word identification, relative localization, it allows us to look at spatial release from masking and reaction time. Within the SINVA task, we simulate 30 degrees spacing of the loudspeakers, so we're only using those that are at 30 degrees separation. There's noise from the left or noise from the right. In this example, we have noise on those red speakers and a word's presented. So here's the babble noise on those 2 speakers, and the word forks presented first and stalks presented second. And then the person has to indicate not only which word they've had, but was it to the left, was the second one to the left or the right of the first one. And we use these 4 word groups that have been carefully selected out of the CHEER auditory perception word tests. The York, I think I mentioned earlier, we've adapted this questionnaire from Quentin Summerfield, and it's a really important questionnaire because it allows us to determine any benefits of binaural hearing, so comparing 2 ears to 1 ear. And it's really hard to demonstrate that for quality of life. So this measure is really important for our trial, and we're making it appropriate for children and teenagers. It essentially has 3 main areas that it's interested in: understanding speech when there's background noise, working out where sounds are coming from, and also effort and fatigue. And then there's 3 categories within those fields that are used to make up the health utility score. Okay, so before I finish, I just wanted to mention about the patient pathway for our clinical trial. I've been through and I've explained some of the outcome measures that we're using. I've explained the intervention itself, and now I just want to say a little bit about the work that we're doing to evaluate it. So we're beginning the trial now, and we're recruiting 384 children aged between 8 to 16 years who are bilateral cochlear implant users. And we're going to use a randomized controlled trial where half of the participants use the bears and half use usual care, so standard care. This is the protocol. Basically, the sections in the shaded rectangles are the key points. So the baseline, where we test our full test battery with the individuals and give them the equipment if they're in the bears arm, and we just follow usual clinical practice for the control arm. At 3 months, they return, and give us back the equipment, and then we conduct the outcome measures again. And then at 12 months, we conduct the outcome measures one final time. That's to look at the retention of the effects, which I think I mentioned earlier. During that period between 3 and 12 months, we also have 2 online sessions where they complete questionnaires as well. So it's a large-scale trial, and it's going to take us 2 years to complete. I'd like to thank you for your attention, but before I close, I'll give you a summary of what I've talked about. So we've used the NIHR MRC framework for complex interventions to develop our BEARS intervention and the associated trial. We've used a series of cycles of feedback and implementation with our participant group because it's really important to engage them when developing such interventions. We're going to run a process evaluation alongside our clinical trial to understand the quality of the trial implementation and how engaged the participants were. And we're conducting parallel work on how we could roll out this, the BEARS intervention within the National Health Service. We have to take into account the service delivery model, how we're going to maintain the games going forwards, and think about future game development as well. Part of this will be to create communities of young cochlear implant users who will share their experiences and be part of the future development. This work is very timely in the UK, and it really fits with the approach for developing more remote care resources. So there's a lot of excitement about whether this rehabilitation approach could be effective and support clinical practice. So with that, I'd like to thank you for this opportunity to speak to you today and acknowledge my funding sources. Thank you.
我把视频打开，但是我怎么看不到他们呢？
可以吗？Hello，孟老师也上线了。OK， 我们看一下那个 Deborah 上线了。OK，Deborah，thank you so much, Deborah, for your excellent presentations. I know this is part of your project, and you are doing quite well on this one. 非常感谢 Deborah 刚才给我们分享了一个非常精彩的一个演讲的一个话题，就是关于 VR 在这个听觉训练当中的应用。那么其实我们也知道，就是说，这种研究还是蛮前沿的，所以我们也非常感谢 Deborah 这一次能够给我们做这样的一个分享。那我们看一下他现在有没有一个 mute， 我帮他解一下 mute。Hello, Debbie, are you online? Because I have saw you online. Oh yeah.
Hello.
Yeah.
Hello. I'm here.
Hello.
Yes. Hello.
Yeah. Nice to see you. I know it's quite early in UK.
Yes, it's 11 a.m. actually. It's 11:30, so it's okay.
Okay. So, I will have our Q&A guest, Professor Mond. He will have to ask questions and have communication with you. Okay?
Yes, that's fine. Yes, yeah. Hello.
好的，我们现在把时间交给孟老师，孟老师你来跟大家做一个沟通跟对答吧。那如果小伙伴有问题，也可以留言或者举手，我们可以用举手的方式来向这个
我怎么看不到他的视频呢？
我可能现在设置只有一个单人的头像，但是 OK 的，没有关系，没事，你可以继续，没有关系。
看不到我是吧？
对，但是小米有在。稍等一下
Hi, Debbie.
Hello. Hi.
Okay. My name is Qinglin Meng. I have organized a special issue on the Frontiers journal that is the digital hearing healthcare. You have one paper in that special issue. Thank you very much for this sharing. Is there any question from audience?
现在还没有，你可能还在写，你可以先问。
I found one question from Dr. Ellen Peng. She said, "Thank you so much for this exciting work. I'm interested in how you determine Attrition is in sample size planning for intervention. What is attrition? How you determine attrition in sample size planning for intervention?
Yeah. Okay, so when we plan our sample size, we actually allow 20% for attrition in the trial, so people dropping out of the trial. So, and that seems to be a standard approach that's used for many clinical trials and is what's typically used by the clinical trials unit that's running our trial.
Mm-hmm. So in this year, you have just started this trial, right?
Yes, that's correct. Yes. Yeah.
And you have shared a lot about this preparation. I think you have shown us how to do a very big clinical study before it is it is starting. And my question is, how can you fit, I mean, wear the headphone or the VR devices to the cochlear implant children, because they are using the cochlear implant devices. Maybe not easy to use the traditional device like ordinary people.
Yes, and that's a really good question. And it's something that's a real challenge when doing a large scale trial, because the options that you have really, so are you talking about the audio? So I'm assuming you're talking about the audio. So we're using headphones to go over the top of the sound processors. Now, we did some work with different headphones to make sure that we could simulate a spatial environment. But one of the things we had hoped to use was Bluetooth connectivity.
Yeah.
But because we're using all devices, and actually we did some pilot work, and a lot of the children who were in the appropriate age range didn't know how to use their Bluetooth systems. So it became easier that we did the same with everyone, which is to use headphones.
So which headphone have you selected?
Oh, I can't remember what we selected. Sorry, I'd have to look it up.
Okay.
I can let you know.
Okay, I explain this question to the audience. 我问了 Debbie， 就是说他因为人工耳蜗嘛，需要训练，因为刚才他讲的过程中并没有讲这个耳机是如何佩戴到这个用户，就是我们的听障儿童的这个身上的。因为人工耳蜗受试这个用户呢，他实际上是带着这个设备的，所以跟我们普通的这种佩戴方式可能会不一样。所以他刚才讲的是也尝试过用蓝牙耳机，蓝牙的方式连接，就通过无线的传输。当然也所有设备不一定都支持了，所以他说还是选用了这个耳机。然后我问他什么型号，他说他也不太记住具体的型号。Okay, Debbie, the second question is,
yes.
Do you think how did you determine how long time to train? You write the 3 months and the minimum 1 hour per week. That is 2 sessions per week. Is that enough? Do you have any preliminary study to show that this is enough long time to have a good training effect?
Yeah, I mean, that's a really good question, and something that we really spent quite a lot of time looking into. It's trying to get the balance between what 8 to 16-year-olds are willing to do and actually what we think is necessary is quite hard. But so we did some pilot work where we gave the games to the children, and they came back and told us that they believed it was possible and feasible in their kind of daily week, in their weeks, to train for 1 hour per week over 2 sessions. So that's basically come from a practical direction. But in terms of the 3 months, we did quite a thorough literature search to find out what seemed to be most a reasonable time period to see an effect of training. And that's what we came up with 3 months from that. And I've also done some previous work with singing training, and actually 20 weeks was the amount that came out as the appropriate amount for that study. So we think it is the right amount of training that should work.
Okay. And about the task, the main task is about spatial hearing. And I think the children every day, they also experience the real life. They have many different sounds localized from different directions, and they're trained every day. And do you think the game will enhance the training much better than the daily life? So that is the basic hypothesis, right?
Yeah, yes. I mean, you're right. We are assuming that this is additional to the kind of everyday listening experience because it's specifically training skills and repetitive training of localization skills. So although it enhances what people do in everyday life, there is quite a lot of evidence that you can train localization skills. So we have one game, the Target Practice, which specifically looks at that. And by doing listening practice with speech and noise, we really think that this will enhance the training. But of course, this is what training's about, isn't it? Adding things to what you're experiencing every day and actually hoping that the training will then cross over and improve your everyday experiences as well.
Can they use the device at home or only in the lab?
No, they can use the device at home, and they can use it for longer than 1 hour per week. That's the minimum we're asking them to do.
How to balance the screen time and the training?
Yeah, I mean, I think that is something important that parents are concerned about as well. But I honestly don't think that they're going to want to do hours of training. It is a training task. And when we did some pilot work with some 18-year-olds with the games, they said we should tell people that it is training to help with hearing because it isn't just like playing games. So I don't think we're in danger of children wanting to use this for 8 hours per day. It's not that it's not that sort of game. But yeah, we have to balance that, especially with the younger children around the 8 years old. We've had to look at that. And also we have the iPad version for younger children as well. So if parents are concerned about them having the headset, the iPad, we can get them to use the iPad version as well.
Yeah, the iPad will be better using the sound field. And I should translate now. And
yes, please.
Yeah. 刚才我问了几个问题哈，看我还记不记得。第一个是关于这个训练的时间，我问他这个3个月训练，每周训练1个小时或者是2个 session 的话够不够？他说好像是意思是，做了很多调研，觉得应该是一个可操作的一个情况，然后够不够？到底效果怎么样？我刚才没太听清楚啊，可能大概意思是说应该可以值得期待，可以看一看。另外，我就是问他那个第二个问题什么来着？在家里用还是实验室用？然后呢，我说这个训练的效果怎么样？他是说也是查了很多文献，他认为，我问这个 Debbie 的意思就是说，因为我们日常生活中呢，小孩子也是在听各种各样的方向的来的声音，那么在游戏里呢，他也是听这些声音，那有什么区别吗？就反正平时也在听，但是呢，他是说了一下，可能在前期的一些调研，这个预实验认为这个是有一些好处的啊，包括那个训练时间。最后还有一些小问题，然后呢，Alan Peng have another question. The trained paradigm is focused on localization, resolution, and not accuracy, precision. Is there a reason for this choice? Debbie?
So yes, so the training itself is actually, we are training accuracy because they actually do a target practice with the localization. But with the assessment, which is the speech test, we use relative localization. And the reason is that is easier to do than an absolute localization task. So to be able to just say whether the sound is from the left or the right is much easier. And because the task is a dual task where you have to identify speech and label the relative localization, it makes it more practical.
Okay, so you mean so you use the HRTF to design the sound, right?
Yes.
And have you ever think about how to separately test the ITD or ILD to train their how to use specific cues?
Yeah, I mean, I think that's really interesting. And in some other work that we're doing, we are looking specifically at ITD perception. But actually, we're doing that work with adults. But I think you're right. Actually, one of the things we were considering is actually adjusting the stimuli so that we can really focus on specific cues. So I think that is something we would like to look at going forwards.
Yeah, because the CI children, I think mainly use the intensity cue and much less using the timing cues. And,
yeah, I agree. Yeah.
Thank you. I translate, right? Alan 的问题是说，这个训练的范式呢，主要关注于这个定位的精度，定位的分辨率，而不是精度或者是准确度。然后他解释了一番，说这个 Alan， 待会儿你来解释一下吧，他评论区好不好？然后我就因为时间我看也差不多了，那个 Stella，
王上姑奇他有一个问题要提问，我看一下。Yeah, one more question. Let me see where is here. 你举手吗 ？OK， 你可以 ，You can go on.
在哪儿呢
Hi, Debbie. Debbie Shang. A great talk. I'm actually you now. Actually, yeah.
Thank you.
Oh, yeah. Okay. I'm wondering, do you worry about the individual differences too big to cover the benefits of training? Because you can't control everything, It's although I know the sample size is quite big. Yeah, I'm still worried about.
Yeah, so I think you're asking me about the individual differences across the participants and whether our training can train all of the range. Yeah, I think what we've tried to do is have a range of levels within each game. So there's 3 games to cover. So in each game we have a range of levels, because even just the individual differences of an 8 to a 16-year-old, it's quite a wide range. So for example, in some ways it's not so much it's the task itself to be engaging for this age range can be a challenge. So within the speech and noise task, for example, we have, for the younger children, we expect we have a pizza game, which I think would be better for them, and for the older ones we have a diner. So I think we've tried to address it, but of course it is a challenge, and we will see going forwards whether we've got it right.
Okay, yeah. Another question is, I'm wondering, is there interaction or overlap between the training session and the outcome measurement, the task? I mean, any similar task will, of course, lead to higher performance in the outcome measurement.
Yeah, well, so we've tried to do assessment tasks, which we consider on task. So some very specific tasks that will relate to the training that they're doing. For example, speech and noise is a good example, but localization. But we've also have some assessments that are kind of far, so the near and far tasks. So something that we think will be generalization. So if we see improvements in vocabulary score, or we see improvements in quality of life, those other elements are, so we've tried to make sure we assess both near and far kind of tasks.
Okay, thanks.
Thank you.
Okay, 翻译一下。Yeah, translate.
就是我刚刚第一个问题就是问了 Debbie， 虽然他的那个 sample size 就是很多，但是呢，你知道像那个人耳蜗的那个小孩，他们的那个就是恢复的这个效果，个体差异还是很大。就他们做的是那个就是那个叫 就是那个随机的分配的对照组的方法，所以这个风险其实我觉得可能会比较大嘛，会因为这个个体差异反而会掩盖了最后的效果呢。然后他的回答就是这可能会是一个问题吧，但是呢他们就尽可能的会去找更多的那个不同年龄段的组，然后可以把年龄段就是进行一个继续的细分，可能可以进一步的消除这些东西。但是呢，300多个人已经是特别大的一个实验了，已经是他们可以做到的一个非常大的实验了。第二个呢，我就问了，对，第二个问题呢，我刚问了就是他们的 training， 就是他们的训练和他们的最后的那个测试会不会有一些相似？因为如果相似呢，那肯定就是那个在那个最后的那个测试中肯定会有比较高的分数嘛。如果他的练习项和最后的考试差不多嘛，然后呢，他就是说肯定会有一些相同的，比如说一些什么在造成压力、言语识别啊、方向的东西呢，肯定会有类似的。但是呢，他们还会包括更多的一些整体的评估，比如说问卷啊，还有什么的其他的一些不一样测试。但他们也会考虑这个问题，然后也会在最后的报告里有一个完整的评估的呈现。对，就是这两个问题。谢谢主持人。
Thank you, Debbie. And
Hello.
we are looking forward to your results.
Yes, so am I. Thank you very much for your time. Thank you.
Thank you very much.
Yeah, I think it's all enough for this section. 我觉得我们可能这一趴就可以结束了，因为可能时间的关系。Okay, thanks Debbie again, and thank you for your time and the excellent Q&A part. I think we'll be looking forward to see more your reports coming out in the future. Okay, thank you.
Okay, thanks very much. Goodbye, everyone. Bye.
Okay, goodbye.
Goodbye.